Want a better understanding of how to assess and approach entrapment neuropathies in the clinic? In this episode, I'm joined by Dan Pilderwasser, a physical therapist with 46 years of experience, Clinical Neurodynamics Instructor, Mulligan Concept Accredited Teacher, and Director of Physioscience Clinic. We will cover how to differentiate musculoskeletal from nerve problems, recognize key nerve dysfunctions, explore how thinking has shifted from a purely mechanical view to include neuroimmune, neurophysiological, and neurochemical perspectives, and share practical tips on upper limb tension tests, nerve mobilization techniques, and when to refer. If you're new here, don't forget to subscribe and hit the like button so more colleagues can find this content, and so you also don't miss future episodes. So now let's dive into today's discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like NeckCare,
treating neck impairment. Get objective neck assessments with the NeckCare system. Learn more at neckcare.com.
Hi Dan, welcome to PT Pro Talk. How are you today?
I'm good, thanks you. Thanks for having me here, and I hope we'll discuss just important things that might be helpful to our colleagues, PTs.
Yes, thank you so much for accepting my invitation. I'm really excited to have another Brazilian here with me today. So let's just get started talking a little bit about yourself and your career so far.
Okay, so I was born in Rio de Janeiro in December. I will complete 46 years in the profession. So I've been working in quite different fields here in Rio. I've been working in public health facilities without patients, and been working for almost 30 years in a private hospital, also in Rio, Samaritano Hospital. During this time, I've been in private practice here in Rio also. We own a clinic, physioscience, and I've been teaching in many physio schools here in Rio. I'm also involved in teaching for Michael Shacklock's Clinical Neurodynamics. So I'm an instructor of Clinical Neurodynamics, allowed to teach in Brazil. And I'm also an international accredited instructor of the Mulligan Concept of Therapy, and I'm allowed to teach in South America.
Before we continue our conversation, I wanted to take a quick moment to tell you about a special offer from Sarah Health. Visit sarahhealth.com/PTProTalk for a 90-day free trial. That's SARAhealth.com/PTProTalk. Make RTM simple to Sarah Health. That's SARAhealth.com/PTProTalk. And now, let's get back to our conversation. Very cool. 46 years as a physical therapist. That's crazy. Almost 50 years of experience.
Old guy.
That's a lot. So you have a lot to share with us. 50 years. Crazy.
Yeah.
And still going. Still passionate about the profession?
Yeah. I'm still. It's challenging every day. So I'm working in the clinic every day. So I see new and different patients all the time. So I've been challenged all the time. And I feel really good about the profession. I like it very much. And I like the teaching experience as well.
That is so refreshing to hear that we have PTs almost 50 years of experience and going strong and still seeing patients. That's awesome. Very good.
Yeah, and still attending courses and reading articles every day. So I think that's the secret. You just have to keep updated all the time. So it's easy. It's not really tough.
You still have the desire to learn more and still passionate. That's awesome.
Oh yeah, that's for sure. I think that's the reason to be active after many years, and it works for me. I don't know if it works for everyone, but for me, I think it's the reason to still go on.
You chose the right career.
Yeah, probably, yeah.
So let's jump to our topic. So could you explain a little bit about neurodynamics and nerve mobilization in simple terms to a PT, for example, that's just starting out so they can understand?
So yeah, the idea was, I think, in the beginning to try to focus more on neuro tissues when people had what we think or what we've been thinking that were symptoms related to neural tissues, like neuropathic pains and sensory motor features. So that was the idea. So to try to find a way to focus more on neural tissues instead of only on the neighboring tissues, the musculoskeletal tissues. So it's been a long time that people try to use this approach with many failures, mainly because of the idea that stretching nerves should be, let's say, the main intervention. And then, of course, people were in a lot of pain, and there were tears in the neural tissues. So it didn't end really good. So people just abandoned the approach for decades. And then in the end of the 80s, the beginning of the 90s, it came back, especially after David Butler published his first book, and with the work of a Swedish neurosurgeon that helped a lot in our understanding of how nerves move, and they can move related to the neighboring structures. So Alf Brage is the Swedish neurosurgeon. He published 2 great books that I think helped a lot for us to understand, to have the understanding that we have these days.
Just a quick pause to share something exciting. I've been working behind the scenes on a tool to make prescribing home exercises easier and faster for PTs. It's built based on feedback from therapists who have told me they are tired of clunky search tools, limited customization, and complicated sharing. I will be sharing more soon, but if you're curious and want early updates, you can join the interest list using the link in the show notes. All right, let's get back to the conversation. Okay, very good. So it started like just trying to stretch the nerve, and then over time evolved. And then today, what would you say that, it's the main intervention or the main approach that it's used, neurodynamics or nerve mobilization?
So the thing was this big paradigm shift from a structural biomechanical model to a biopsychosocial model or a person-centered approach. And mechanics was not the main feature. So we started to understand that there were pathophysiological changes within the nerve structures that we should address it before we address mechanics. That explains the failure with the stretching, because neural tissues were, let's say, affected because of pathophysiological changes and could not adapt to mechanical stresses. So this was the big change. So what we try to understand these days is what's not really moving well in the neural tissues. And it can be, of course, because of tension, but it can be because of sliding properties between the nerve and the surrounding structures. So we try to diagnose this with neurodynamic testing.
Mm-hmm. So it's not just purely mechanical, and it's also just not, the nerve itself as it was believed in the past. I guess that's what I understood from how things evolved, right?
Yeah. This was the big change, and when we started to understand that mechanics and physiology are completely linked, and one cannot live with the other. So we try to integrate both, and integrate both with function, with active tasks, with movements that make sense to the person. So this was a big change.
And we were discussing this before, and you sent me a few papers talking about the neuroimmune factors involved in all of these as well. So would you just tell, I know it's very complex. That paper was very difficult to read and to understand, but just to give us the main idea, how is that involved in the neurodynamics, in the nerve mobilization, these neuroimmune factors?
So first, as I said, we've been thinking about biomechanics all the time, and we actually concluded that it was not enough. So, of course, when we use neurodynamic testing, we are searching for mechanosensitivity. But mechanosensitivity can be explained by many different conditions. So it can be a problem within the nerve. So when we think about neuropathic pain, so we think that there is a disorder that it's caused and it's in the neural tissues. But there are many times there's no lesion in the neural tissues and you still have a lot of pain. So you might have an increased and abnormal response during a neurodynamic test, but there are other key players like, of course, neural cells, but also immune cells and glial cells that normally they are capable of producing a normal immune response. So there is emerging evidence now that the immune system and the nervous system, they work together to accomplish many bodily functions. And so when you link both of them, so you have the neuroimmune system that its function is to monitor, to transmit, to process, to predict, and respond to information about potential threats or dangers that we call nociception. So when we have the descriptors of pain, actually, we are talking about nociceptive, neuropathic, and nociplastic pain. And some of these mechanisms are not quite clear for us. So many times it's hard to understand. So this is why research is aimed to explain and to find a little bit more about these mechanisms and how to explain the patient's symptoms. So it's a little bit tough. It's quite complicated, but it's a good reading for people that are interested in more neurophysiology and about the immune system.
Mm-hmm. And just considering everything that you just mentioned about this, the neuroimmune role in all of that, how would it would if it changes anything in our practice in the clinic? is there anything that, we should think about differently when treating these patients, taking into consideration all of these factors?
Yeah. I think a lot. I think it's helping a lot. First, we should try to identify the level of protection that our patients present to us. So people are completely different according to their previous experiences and thoughts and what they believe. So it changes their behaviors. And of course, the neuroimmune system is present in all these different clinical scenarios. So if we aim to help these patients, these people, to create adaptations with our protective responses, so we can identify the need to use top-down approaches or bottom-up approaches according to each individual features. So I think this is the idea right now.
Mm-hmm. Mm-hmm. Okay. And then, so let's say from all of like the research and all these things coming up, is there anything specific that you find relevant from this research that we should be aware? Just maybe like one key thing or something like that?
Well, when we identify, let's say, specific individual features in these people, so many times we just have to try to calm down the whole system. So, and this is I think one of the tough things about the PT's choices, how to understand and identify that person in that specific moment, when you need, instead of expose, to step back a little bit and calm things down. So Greg Lehman, which is a colleague from Canada, he says that we should understand when we have to calm shit down and then build shit up again. So I think this is really important. So many times when you see that there is a lot of stress and people are not dealing quite well with the stress, you have to use, let's say, explicit learning, gaining of knowledge, mindfulness, and then try to expose again with movement-based interventions, engaging in meaningful activities. So this is quite personal. So this is something that I think it's very important. People always try to look not at the whole picture, but people try to follow methods and concepts in a very, I think, not really directed to that specific person. So I go to a course, I attend a course, and I learn about neurodynamics. So I try to, of course, to apply that to everyone. It cannot work. It cannot work if you don't get the whole picture, if you don't identify the protective mechanisms that are being adopted by that person related to their symptoms, related to the environment, and related to their social role. It's completely different. So our intervention should be aimed also to this.
And now, since you were mentioning about selecting the patient that needs that intervention, so do you have any tips for our listeners here? How would they select someone that needs that intervention, the neurodynamics, or not?
Most of the patients that come to us with a sensory motor disorder or with pain that we might think it's related to the neural tissues. So and many of them are diagnosed with compressive or entrapment neuropathies. So when we think about these neuropathies, if there is a compression of an entrapment, the neural tissues are being entrapped or compressed by neighboring tissues, usually musculoskeletal tissues. If there is pressure, it might be because of a change in the size or the form of these musculoskeletal tissues. So I always find very helpful to assess the musculoskeletal system before we do a neurodynamic assessment. Not saying a neurological assessment, which must be previous to the musculoskeletal assessment, but a neurodynamic one should be after you identify that there is or there is not a musculoskeletal issue. So we should treat the musculoskeletal disorder before, and then we try to understand. So what happened to me personally was that I have attended neuro stuff courses before, but when I went to Denver, to Colorado, to Michael Shacklock's course, I think it was 25 years ago. Yeah. So I think Michael Shacklock developed an algorithm that helped me personally a lot, because it allowed to classify the responses produced during a neurodynamic test and classifying the dysfunction. So when you ask, when I decide to use a neurodynamic approach, I decide to use it when I find that patient is suitable for that. And what does it mean? It means that I could reproduce during the neurodynamic test totally or partially the patient's original symptoms. And here is a common mistake that people do, is to think that producing symptoms in a neurodynamic test is abnormal. It's completely normal. You are loading the nerves and they respond, and the brain responds kind of a feeling of a threat or a potential harm to the tissues. So it's normal. It might be normal. Of course, there are signs of abnormality like allodynia, burning sensations, electrical shocks, and a different anatomical distribution of the symptoms. But the most important thing is to reproduce partially or totally the patient's original symptoms. So then I decide if I can use it or not. And of course, it will depend also on the symptom status of the patient. So the more irritable, the more severity I find, of course, I'll think more about pathophysiology and not about mechanics. So we have to think of restoring physiology, normal physiology, before then trying to use a mechanical approach. So I think the Michael Shacklock's model helps a lot with that.
Mm-hmm. And when you say restoring the neurophysiology, I think that's what you said. How would you do that in practical terms?
When you think about entrapment and compression, David Butler describes the nerve as a vampire, thirsty for blood all the time. So most of the entrapment neuropathies are due to ischemia. So we try to give that neurostructures the chance to drink that necessary blood. So many times what we use is positioning. So positioning the limbs or the patient in a position that allows for a better vascular function, because this is the most important thing. So you cannot think that a neural tissue can have its normal properties of sliding, tensioning, promoting axonal transport if its vascular status is not normal. If there is ischemia, the neurostructures do not respond well to movement. And of course, this is a problem. So depending of the findings in a neurodynamic assessment, depending on how I classify this patient, if I think the problem is more of a pathophysiological or more biomechanical. So many times we just try to position the patient, aiming that neurostructure will restore its normal vascular status.
Mm-hmm. So like you have like a systematic way of like assessing to then be able to classify and know like what technique to use or what approach to use.
Exactly. This was for me the great asset of attending Michael's course and knowing about his algorithm exactly to grade the patient status according to, is this patient ready for movement, or is this patient in need of restoring its normal physiology before I start moving? Yes.
Mm-hmm. Okay, no, that's great. And then when you say ready for movement, then you are referring to the sliding techniques, the tensioning techniques, those type of things?
Yes. So in the same algorithm, you can diagnose sliding or tension dysfunctions. So when you are performing the neurodynamic test and there is a neuro response, and what do we consider a neuro response? So when you perform a neurodynamic test and there are symptoms, the first question you need to answer is, does it look like more neuro or musculoskeletal? So we use a tool that it's called structural differentiation, which is to move a bodily part that is far from the site of the symptom. So this is when you are doing a median nerve test, and you extend the wrist, and there is pain in the close to the wrist, so you move the head in a contralateral flexion. And what you ask the patient is, did your symptoms change? And it doesn't matter for better or worse. If they change, it might be due to neural action. And if it doesn't change, it might be just musculoskeletal, because when we move this distal parts to the symptoms and it changes the symptoms, we are influencing much more the nerve system, the nervous system, than the musculoskeletal system. So, and then you perform pure sliding or pure tensioning techniques to diagnose if there is a sliding dysfunction or a neurotension dysfunction. And then you build your treatment.
Okay, so then you also have a way to differentiate between the sliding and the tensioning techniques during your test.
Yes, and what we see more in clinic, and it can be a little bit surprising for many people, is that the most common neuro tissue dysfunctions are the sliding dysfunctions, and not tension.
Because everybody thinks about tension right away, right? You gotta
yeah. And because when we add tension to the system, adding different movements, of course it hurts, but it's normal. It's a normal response. It's a normal neuro response. It's just nociception occurring, and the brain saying, well, maybe I don't want to play this game. Maybe it's not good. Maybe it's not a good idea. So it's an alarm, and pain is just a defense response. It doesn't mean that there's a lesion, doesn't mean there's a problem. So it's normal.
So, okay, now my question. So how do you, if it's a normal response, right, to feel pain when you're putting tension on the nerve, how do you differentiate if that pain is just a normal response or if it is, I guess, when it's the patient's symptoms, when the patients, they already have those symptoms and you are reproducing, then is when you confirm, versus a person that doesn't have symptoms and you put tension and they feel that tension on the nerve?
Yeah, exactly. So what is considered a positive? We don't like to use the word positive for neurodynamic tests, but if we use positive, what is positive? Because in the beginning, positive was to produce symptoms, which were normal. So everyone has a positive response. So that's not true. So to be considered a positive neurodynamic test is to reproduce, total or partially, the patient's symptoms and to change these symptoms with structural differentiation. This is really important. So I produce symptoms, I move a part far from the symptom site, and I ask the patient, did your symptoms change? And he answers, yes. So when I have a positive structural differentiation, so it's a neuro response and not a musculoskeletal response. So this makes the test positive. But it has to be according to the patient's symptoms and not a symptom that the patient says, look, I never felt this before. It's completely new for me. This is probably completely normal because everyone will have, let's say, a positive test if we just load nervous system. So this is a common mistake for people.
Mm-hmm. Okay, so I'm gonna go back and try to summarize what you said, and you correct me if I missed any part. So first, you have to identify if the tissues have normal physiology, if they need more blood supply or not. before you jump to the more mechanical assessment, right? And then you do the neuro tests, the neurodynamic tests, to identify if it's more musculoskeletal or neuro symptoms. And then from there, you're going to classify to see if they need more sliding or tension on the nerve.
Yes, because there are many patients that when they come to us, we cannot perform a neurodynamic test. It won't be conclusive for us. So these are the people that we must think before about restoring the physiology. Let's say you have a patient with a radiating pain to the lower limb, and every test you try to do, the SLR, for example, or LASEG, as people call it, or you just try to start raising the leg, and it's crazy painful. You cannot come to any conclusion. So this is the moment that it's not really important to make a diagnosis of a neuro tissue dysfunction, but it's more important to understand that pathophysiology is just screaming there, and we must do something to calm the system.
Mm-hmm. Okay. And then when you're differentiating between the sliding and then the tensioning technique, is through these neurodynamic tests as well?
Yes. When I get to that point that I make the structural differentiation and the patient answers me that yes, my symptoms change. So I try to give the patient a whole proximal sliding and then a whole distal sliding, and I see what reproduces the pain. So people with sliding dysfunctions, their first behavior might be during the test when I do a different structural differentiation, adding more tension, that when I ask them, so did it change? And they say yes. And I ask them, but what happened? And they say, it's better. So when I added more tension, they say it's better. So maybe it's just because I moved the nerve in a direction that it's better for the patient, even though it's with tension. But then to diagnose, to make a diagnosis of sliding dysfunction, I must release the other extremity so that the force is applied only to one direction. And if he says it's good, it's completely good, so the sliding in that direction is good. But when I try the other way and people say, no, now I have my pain. So we diagnose proximal sliding dysfunctions and distal sliding dysfunctions. So this made a lot of difference because so when you start treating, so if I have, let's try to, okay. So I'm here in the median nerve and I'm here and there is pain here. When I do this, they say, oh, it's better. So I release here and they say, it's much better. So sliding proximally, it's good. So I come back here and I'll release now the cervical, the neck. And when I go here and I allow only distal sliding because I'm releasing here, they say, here's my pain. So it's a distal sliding dysfunction. And how I start working with this patient, proximal, bringing the nerve in its preferred position. So, of course, we are dealing with physiology. So I'm allowing physiology, I'm allowing restoring the vascular status. So this is, of course, this is part of this algorithm that we use in clinical neurodynamics. Of course, there are people that don't use it. This is really Michael Shacklock's idea. But there are people that they just bring the patient to do what feels comfortable, which is okay. So we try to make people make sense of the pain, what is safe for them, and try to move in a safe way. So this is also a system. So these days, if we are thinking about how healthcare is going on, that people must try to use self-management a lot. So teach the patient and make the patient experience different movements and sports-related movements like swimming, boxing. You can actually mimic neurodynamic tests and try to expose these patients gradually to their problem. So there are different approaches, of course, and we must just find out what's going to be better for that person.
Mm-hmm. You're trying to use more functional movements so they can go back to their day-to-day activities.
Yes. This is something I try to do, because the neurodynamic testing is a passive approach. Of course, we must teach the patient to deal with it. So the neurodynamic tests help me to diagnose a problem, a dysfunction, and from there, of course, when I understand that I can progress with a gradual exposure and gradual activity, so we train the patient to do it. And it can be fun, it can be dancing, it can be many different ways.
Mm-hmm. And then when you are classifying, going back to the sliding and tensioning, so you classify according to the patient's symptoms, right? Like we were describing before with if you are not. And then you always, it seems like you start with a movement that is not irritating the nerve. So
exactly, yeah.
It doesn't reproduce the symptoms.
Yes. If you have a distal sliding dysfunction, you always start with proximal slidings. If you have a proximal sliding dysfunctions, you start with distal. If you have a neural tension dysfunction, of course, you try with very gentle sliders.
Mm-hmm. Okay. And then you said that sliding is more common than tensioning?
For dysfunctions, yes.
Yes.
Yeah, it's quite amazing, because we were used to think about tension all the time, and the tension, of course, can hurt, because normally is what we see. If you take completely asymptomatic people and we do neurodynamic testing, when we add tension, they feel worse. So yes, that's the idea. But with the dysfunctions, not really. They have more slidings.
Mm-hmm. So the dysfunction is a different classification for, what is the dysfunction classification?
For neural tissue dysfunctions, you have proximal and distal sliding and tension dysfunctions.
Okay.
Yeah. Of course, in the whole algorithm of Michael Shacklock, there are also what we call the mechanical interface dysfunctions. That is the musculoskeletal system. That's why I said that we should screen the musculoskeletal system for any disorders and try to work with it. So before we start with with the neurodynamic stuff. Yeah.
Okay. And in your experience, which one are more common? Which one is more common, the mechanical musculoskeletal or the neuro?
Of course, the mechanical interface,
Yeah, that's what I thought.
and usually they come together. When you have a neural tissue dysfunction, you have probably a musculoskeletal problem. I would say not disorder, because many times we just don't know. the where we used to think that we know a lot. We don't know. So we learn a lot with the patients. So this is why we should spend a lot listening to the patient, because it's the best source of knowledge for us.
Yeah. And then I assume if you could have mechanical interface, it'll have the neuro more commonly than
Oh yeah, sure. Yeah.
If you have neuro, you probably have the musculoskeletal with it, but you could have just the mechanical probably more commonly.
Of course, what makes me think of a neuro problem is the quality of the symptoms and the pain that I can link to a neuro tissue, and of course of sensory motor changes. We have to. It's not only about pain, but you have paresthesia. You have a decrease in muscle force. So these are signs of, let's say, when we think about radiculopathy. So these are the main features, the sensory motor changes.
Mm-hmm. Mm-hmm. And then I remember one of the papers you sent me that I read talking about tension, right? Because tension is something that's good for the nerve, but you can't do too much tension because then it's going to irritate and make it worse. So how do you know what is the proper amount of tension or load on that tissue?
So let's say when we think during treatment, the neurodynamic test is, let's say, is what guides me, because you are there, you are making a diagnosis, you are identifying an abnormal neuro response, which has to, as I said before, reproduce partially or totally the patient's symptoms, original symptoms. It's completely different of a symptom that I have doing this. And I'm completely asymptomatic. So I'm just loading and my brain is saying, oh, no, maybe this is not a good game to play. So producing symptoms is not a problem. Let's say when we stretch muscles, it's painful. Is there a problem there? No problem. It might be harmful, maybe, or not. Depends on the load, depends on the time of exposure. It depends. So we usually respect the patient's, let's say, thresholds, and I don't want to expose. Let's say if we're talking 10 years ago about doing exercises in pain, I would say no, never. Today we expose the patient in a scale of 10 to 4 or 5 of pain during exercises. You can treat a person these days with elbow tendinopathy, lateral tendinopathy, without bringing the pain in 4 or 5 in a 10 scale. Otherwise, it will not heal. So, but it depends a lot. It depends of the patient. It depends how is the status of kinesiophobia and fear of movement and his previous experiences with pain. So this is really very tough to identify, because it's really personal. So that's why I don't like, let's say, some protocols being adopted by a whole population, because people are completely different. So gradual exposure, yes, is the idea, but you have to reach some minimal physiological features to do it.
So it's like it's okay to reproduce the symptoms as long as it doesn't aggravate or
Yes,
doesn't make them worse.
Yes, especially the day after. The day after is something that we should understand. So that's why, let's say, in the beginning, or in a very irritable and with a high severity patient, we don't want to do a lot. So we do some repetitions, we expose a little bit, and then we check for the response. Again, Greg Lemon's calm shit down and then build shit up again. So that's a fantastic idea, fantastic way to understand what we should do.
Yes. Okay. And now I just wanted to briefly talk about the upper limb tension test that you how to interpret those tests. I remember like one of the papers you told me like how to rule in and rule out. Do you want to just briefly mention that paper?
Yes. So there are some papers about it, and it was specific to if using upper limb neurodynamic tests, it would help to diagnose cervical radiculopathy. So yes, the cluster of the three, let's say the median, the radial, and the ulnar nerve together, if they are positive, reproduce total or partially the symptoms, and change with structural differentiation, they really are a good tool to rule in cervical radiculopathy. And if they are negative, they are a very good tool to rule out cervical radiculopathy. The other neurodynamic tests are not really good to diagnose entrapment neuropathies. Okay, there are a huge effort with the median nerve to try to help diagnose carpal tunnel syndrome, but till now, we don't have good evidences. So neurodynamic tests to diagnose entrapment neuropathies are not really a good tool. They are a good tool to understand pain and nerve pain related, but they are not good to diagnose entrapment neuropathies. And there's something that must be very clear. So negative neurodynamic tests do not exclude a diagnosis of entrapment neuropathy, and positive neurodynamic test doesn't mean that there is an entrapment neuropathy. These are different things. Neurodynamic tests are used only and are helpful only for mechanosensitivity. They don't teach us about integrity of the neurostructures, and they don't teach us about function. There are different tests for it, and it's not a neurodynamic test.
Very interesting. Yes.
Very interesting. Yes,
Very
indeed.
Yeah. So that's a little confusing. We gotta be careful.
That's simple. That's it. Neurodynamic test, check for neuromechanosensitivity. That's all.
And they help you on the diagnose.
Yeah. Oh, yeah. For dysfunction, yes. Sliding, tensioning, yes. they don't explain what's causing the problem. No.
Then you have to know how to do those differential tests that you were mentioning to kind of.
And then you have to know if that patient is in your professional territory. Because when PTs are, let's say, primary carers, they should understand if that patient needs a medical diagnosis, which is a huge problem in many countries.
And since you were talking about it, so when do you refer out? What are some signs and symptoms that make you think about referring?
When there are red flags enough to bring me to an idea that there is pathology involved, and we need a medical diagnosis. I remember my first neuro stuff course was in San Francisco with David Butler. I think it was in 1995. He said that the medical diagnosis is helpful for two things, and for us, PTs. And there were a lot of doctors in the audience, and they started, oh, what's going to be right now? And he said, oh, no, I'll explain. So medical diagnosis is helpful for PTs to know about contraindications and to establish prognosis. This was genius. You don't know the diagnosis. How can you establish prognosis? And you live in the States, you know that a lot of legal actions in the States now are related to the lack of prognosis. So, yes, this is something that I think us as in countries that we are primary carers, we must be aware. And many times, just refer the patient to the doctor. That's it.
Okay, great. Well, we talked a lot about a lot of different things. So I wanted to ask you about resources. If people want to learn more about this topic, like you send me a few papers, is there anything that you recommend people go to read or listen to?
I think there are some good resources. And of course, I have to cite neurodynamicsolutions.com. So it's Michael Shacklock and Clinical Neurodynamics webpage. So there is good information there. So I must declare I'm a little bit biased about it, because it made a huge change in my practice. Understanding Michael's model and the algorithm. There is no group of Butler and mostly the explain pain stuff, which I think is super valuable. And there is this new book by Benjamin Boyd, which is fantastic, which is called Bodily Relearning, that I think it's a useful tool, a little bit different from the clinical neurodynamic stuff, but it's more of an active approach that we can teach the patient. So I think things work together. So of course, there is the passive examination and the diagnosis of the dysfunctions and how to progress from a very, very sensitive, irritable patient to a patient that we can expose more, and we can, of course, use it within the clinical neurodynamics Michael Shacklock's model. And there is the idea of providing people with more active tools, let's say, to expose themselves gradually, to make sense of their pain, and to explore more free movements. Motion is lotion. Yeah, the old idea that it's still really very important. So I think these are the best resources. There is Michael Shacklock's book. I saw it. It's still in Amazon. Clinical Neurodynamics. Fantastic way to explore, I think, this subject.
Yeah. He was here with us right at the beginning in episode 6, I think. So if people want to go back and listen to that episode, it's been a while. Go back to 2020. And if PTs then that are listening could take just one practical message about neurodynamics into clinic tomorrow, what should it be?
First, I think that listen to the patient in front of you. This is going to be the most valuable resource for what we do. People usually explain and tell us what they have and what they want to do. And we should respect that. Don't do over treatment. Don't do over diagnosis. It's a mess. It's bringing our healthcare systems to failure. So let's try to understand many things are much more simple than what they look. So try to help people, but stimulating them by showing them that there are many ways to cope with their symptoms, help them to make sense of their pain, and help with active interventions as possible. So this would be my and look, 46 years in practice, a lot of paradigm shifts, and it's okay. It doesn't hurt. I'm okay to change all the time and to adapt to the new knowledge. And yeah, it doesn't hurt.
Yeah, it's been 46 years, so things have to change, evolve, right? You have to evolve with them. It would be strange if they would not evolve.
Of course. And it's okay. It's okay.
Yeah. And before we wrap up, then anything else that you want to mention about the topic, everything that we said? Do you have any final thoughts, or you think we're good? We talked about a lot.
No, I think the main topics I think we've covered, and but I think we shouldn't be afraid of pain. So pain is annoying, of course, but many times pain is and the level of pain is a reflection of what's happening to us internally, but also related to the environment that we live. So many times we have to deal with it, to think what's going on, and to try to make changes, to change a little bit our behaviors, and of course people can deal much better with their pains when we manage to identify these obstacles. So this will be my take then, and something that I'm really using in my daily practice.
Very good. And then if people want to learn more about you or contact you, is there any way they can find you online? Do you have any social media, anything?
Yes. I'm in Instagram. I think that's where I'm more active. Still on Facebook, and less on LinkedIn. But yeah, I think in Instagram, yes.
Okay. Very good. I'll make sure to put that on our show notes so people can go look for your information. Well, Dan, thank you so much for taking the time to join us today and discuss a little bit about neurodynamics, nerve mobilization, and your career and your experience, almost 50 years there. So I appreciate you taking the time and accepting the challenging of coming here and speaking English, discuss this with me. So thank you very much.
Yeah, it was really challenging. I hope it would be helpful for my colleagues all over the world. I apologize for my English, but it was a good chance, I think. Thank you, Mariana, for having me here. I really appreciate that. And hopefully we meet again.
Yes, you did great. It was awesome.
Thank you.
Thank you, Dan.
Thank you. Bye-bye.
That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day and it really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes, along with more information about our guests, resources, website, and social media. Thanks again for listening, and until next time.